Hello.
Hello.
Nice to meet you finally.
Thank you. Very nice to meet you all. How are you guys?
I think we're doing well. We're pretty excited about today.
Oh, that's awesome. Very awesome. Actually, let me get myself centered. Um, I have done a little bit of research and I am absolutely amazed by the Faithfully Female Foundation. It is basically like you guys took my mission and transformed it and made it very appropriate for your audience. So I'm very excited because I think that I don't leave my spiritual walk outside of my job. It's an extension of who I am. And so that's why I do what I do. It's because I want to please God. So I'm very happy about that.
That's incredible. I think we were talking about how when Samantha reached out, I was like, wow, this is like an answer to all of our prayers. Like this couldn't be more perfect. I was like, wow, this is great.
Yes, God is good. Okay, so I looked at the question. So the way that I would love to approach this, if this is okay with you guys, is to discuss it from a general gynecologist, because that's what I am. I know a lot more than most gynecologists know about fertility because I do everything until IVF and ICSI. But I'm going to kind of keep it, unless someone really needs answers, I'm going to kind of pull back a little so that sets the expectation for every gynecologist, basically. I hope that's okay with you guys.
Yeah, that works perfectly.
Yeah, I think so.
Yeah, and the questions are really interesting too, so that was good. Very good. Just send it to me.
That's perfect.
We're hoping that, my name's Allie, by the way. Nice to meet you. I'm our business director, so I'm just going to kind of be in the background. I wanted to listen and watch and see how this goes. So how'd you get into this field? What made you want to go down this route?
So I thought I was going to be a dermatologist because I had like 95% acne and 5% skin on my face. You can believe it, but that was my whole existence. The day that people went to pediatricians and dentists, I went to the dermatologist. So I was like, they're all fabulous. They all have like multiple clinics everywhere, so they could be a boss. That's one of the fields in medicine. Like almost everyone becomes their own practice owner. So I thought this is going to be perfect for me. But then, and I started dermatology research as soon as I went to med school. I was traveling like 2 hours because we didn't have a dermatology department. I would go, I would learn. I was doing salicylic acid research. And then I then got to where I was about to go into it was my second year, my twin brother passed away. So he passed away from complications of sickle cell. And when he passed away, like our last conversation was actually kind of weird. We were driving home. He was in law school in New York. I was in med school in New Jersey. And we're driving from Maryland. Our youngest brother was in the back sleeping. And the whole time we had this conversation about legacy and what we wanted to do with our family legacy and all these things. So as we were driving, we kept driving and we went through this whole 3-hour conversation. And then after he passed away, I finished up my second year of med school, but I was like done. So I decided I was going to pursue a dermatology research fellowship that took me to Southern Africa, Botswana. So I lived in Botswana for a year, did research there. While I was there, it made me reconsider like my life because, this tragic event just happened. Where do I want to go? How am I going to live out this dream that he literally gifted me right before he died? And so as I was going through it, I realized that I love only one thing in dermatology, and it was cosmetics. And I realized I could do cosmetics in GYN, but I loved everything else. I'm really good with my hands. I'm somebody that can recreate anything. I mean, some of the things, like if you've seen the flower crown on my on my feed, I made that. Like I can recreate stuff. Like I can see something and redo it. And so that's what is good for a surgeon. And being in Africa, I also realized, all these women have fibroids. This is going to be like a perfect thing for me. I'm Nigerian, number one fibroid like country in the world. So it started gearing towards that. And when I came back, I did both dermatology and OBGYN sort of rotations to try to figure it out, because now I'm like confused. When I did the OBGYN rotation at Georgetown, which is where I actually went for residency, one day in the middle of the night, I was doing the 24-hour, I just woke up and was like, this is it. And I stopped my applications for dermatology. And after residency, I can't tell you how crazy the doors open. Like, I was literally said that yesterday. It's like doors open and like a red carpet is out for me. It's like things I never thought I would do. I mean, I've been appointed to all these positions that I never even dreamt. I'm like, I'm 34. Don't you have to be 15? Don't you have to be 16? It just happens. So I know this is my destiny. And I've heard my patients say to me, like, you know, old, young, I never knew I would meet a gynecologist like you. You spend so much time with me. But that I can do because of owning my own practice. I can sit down and I can be like, I'm only going to see 10 patients. I don't care if I don't make as much money as everybody else. That's okay. But then I have good ties, good relationship with my patients. And when I finish with them, like women that have myomectomies or hysterectomies, they're coming in, they're telling me how I've changed their lives. And that to me is knowing that I'm working in my purpose, you know? And so, and I still do a lot of the cosmetic stuff because that's what I like to, but I didn't have to go a route that I knew wasn't the perfect fit for me just to get that little part.
That's so cool. That's
Incredible.
That's my story.
I love it. Oh my gosh. I'm going to fly to Texas. You can be my gynecologist. I don't care if I have to get on a plane. I'm coming.
You guys are always welcome. I live in about 30 minutes from Dallas, 20 minutes from Fort Worth. So I chose that location because the trajectory of 15 to 45-year-old women is like going like this. The ISD is the best in the Dallas area, their school district. So that's why I chose that, because I wanted to help moms and help teenage girls. So you're welcome. I mean, we'll hang out. We'll see Dallas. Dallas is fun. I'm from DC, so it's no DC, but it's fun.
That's incredible. Do you also like specialize in like certain like diseases that African Americans are more prone to? Because I know that we have a gynecologist up here at Mayo Clinic that specializes in that, and I always found that really interesting.
So I specialize in 5 things, and I chose that. Even being a generalist, I've gone and gotten extra certifications in all 5. So my number one thing that I see is fibroids. So I can do every single treatment that, even there's a treatment called Sonata that came out in 2019. I am one of 2 people in the state of Texas to be trained. Like I came back from Sierra Leone, which is where my boyfriend is. I came back from Sierra Leone on like one day, dropped my bags. The next day I was on my way for the training because I had to be at this training. But I do every procedure except for one. And the one that I don't do is what the radiologists do. And I'm trying to figure out how to get trained because I want you to be able to have all the options. And then I do PCOS, polycystic ovarian syndrome. Most commonly, it's actually in Hispanic girls, than more African American women have it. But so I do PCOS. I do infertility support and workup. I do it all the way to when you need IVF. And I decided to do that because there is a discrepancy with payment plans. And if it's coming from a general gynecologist, insurances will pay for it. A lot of insurances will pay for it. But when it's coming from a REI specialist, a lot of the time, you know, they won't pay for it. And so that's why. And then I do menopause management. And this is actually a really strong influence from my mother. My mother is a geriatrician. So she is a physician for old people. And when I was finishing residency, she was like, you know nothing about that. And I was like, it's kind of true, because residency, we have younger patients, we have Medicaid patients, we do a lot of pregnancy. And I was like, I don't really know much other than women's health study. So I went and I got an extra certification where I studied, took the exam, went to the course and everything. And so now it has given me this whole other like passion for women who, because menopause is, a lot of people think menopause is just a menopausal transition. that 2 to 7 years where they have all these symptoms. But menopause is really a new phase in your life, because once you stop having periods, you're not going to have periods again. And if you do, that's sinister. So I want women to have the best possible life then. They shouldn't have to deal with mood swings and foggy thoughts. They shouldn't have to deal with a dry vagina for the rest of their lives. They shouldn't have to not have intercourse and not know what to do about it. So that's what I dealt with. I think did I say sexual dysfunction? So I am the darker, younger Dr. Ruth. So I answer questions like her, blunt and to the point. Because every time I watch her videos, I'm like, you're 87. Like when she was 87. Why are you talking about sex like it? And she knows her stuff. So I did that, and then I do pregnancy. I only do about 10% pregnancy. And the reason why I only do 10% pregnancy is I can't take care of women the way I actually want to, running all these different things. So I take breaks in taking pregnant women because I want to be able to devote a lot to you.
I love that. That's great.
I think have a couple people that are waiting to be accepted. Yep. Are you good if we just start letting people in?
Yeah. Perfect.
Cool.
Yep. Good. They're all good.
I'm going to mute myself just so y'all know. I'm just going to step back.
Yep. Those are all good.
It's so nice talking with you.
Nice talking to you, Allie.
Those are all good there. Yep. Awesome.
Hi.
Hi.
All right. Perfect. I think we're waiting on a couple more here, but we can kind of get started. I want to introduce myself. My name's Gianna. I know I've been contacting you all separately, so I just wanted to say hello. This is my colleague, Michaela.
Hi.
Want to introduce a special guest here, Dr. Arumala. She's going to be letting you guys, answering a lot of the questions that you guys have sent me, but she's also going to be, helping out, answering any other things that you have going on. So I think we're waiting on some more. Can you open up that waiting room?
While we're waiting on some people, I just wanted to introduce myself. First of all, I am so excited to be here. You have no idea. I am a gynecologist in Mansfield, Texas, and I actually specialize in fertility support. That's one of the five, I was just telling them, that's one of the 5 things that I specialize in. I am by no means a reproductive endocrinologist and infertility specialist. Those women usually have 4 years of OBGYN training and an extra 3 years of subspecialization. I have 4 years of OBGYN training and an extra year of surgery training. So I do a lot of the reproductive surgery issues. But because of that, when I was going through the process, I had so many patients that had so many questions that wanted me to kind of break down what was happening when they went to see their REI. And so I took a lot of time to educate myself and attend a lot of webinars, seminars, and certifications to get to the point where I can talk confidently about what was going on with my patients, who were just such a big part of my population. So I would say about 60 to 70% of the women who see me are seeing me because they need to have some kind of surgical intervention and want to get pregnant. So I'll be the girl that's doing a lot of uterine saving techniques such as myomectomy, removal of fibroids, polypectomies, removal of polyps, while still reconstructing the uterus to a place that it can hold a baby. So I am that girl. So I just wanted to introduce myself and let you guys know why Pink Stork thought that I should even be answering these questions. And I'm glad that you guys sent in some questions. Some of them are really, really amazing because they are such a crux in the reasons why a lot of women have infertility issues, or couples, because fertility is not a woman's issue, it is a couple issue. And I have to keep saying that because forever, especially I'm African, so forever, especially my culture, it was always a woman's issue. It was always a barren woman. And a lot of the times, we don't even have the issue.
Awesome. I think we should get started with maybe some of the questions that we sent into you earlier. That way we can kind of answer most of the questions that they had kind of going on, if that's okay with you.
Perfect.
Awesome.
And I just wanted to ask, just for logistics, I think some people have their selves muted and don't have their self muted. With Zoom, if you just mute a little bit, like, we can all hear you, so.
Awesome.
All right, so do you guys want to start with the questions?
You guys submitted a bunch of questions, which is awesome. But we're going to start with question number 1 was, how does weight affect fertility?
So weight is a really big issue when it comes to fertility. And I think that a lot of the times we always talk about being overweight or obese, and that as that being the cause of infertility. But either way, low BMI or body mass index and high BMI or body mass index both are not advantageous for fertility. So it's defined, the way that the American Society of Reproductive Medicine defines this is that we define it as having a BMI of less than 17 or greater than 27. And unfortunately, we live in North America, so a lot of women don't fit into this narrow box, okay? And the problem also is that over-exercising can cause you to have what we call hypothalamic amenorrhea, or you don't actually ovulate because you're so stressed out from extra exercise. So I'm gonna start off with the high body mass index first. So what happens is that fat itself, or adipose tissue, is not inert. It doesn't just sit there and do nothing. It actually can have hormonal changes. So it takes some hormones that are circulating in your body, and it will change the hormones to extra estrogen. And that can cause you not to ovulate because the hormone levels have kind of shifted out of order. So that is one of the things that can happen with high weight. Another thing with high weight is that a lot of the times you can also have insulin resistance. So that means that your tissues don't actually take up the insulin and actually use them. So the insulin remains high in your blood circulation. And what insulin does is that it mimics other kinds of hormones, and it binds to what we call sex hormone binding globulin. And when it does that, it reduces what is available for what the hormones that actually should be bound to this carrier. And so then you have more androgens or more testosterone circulating in your body, and that also throws off ovulation. So those are the major 2 things that happen. So when we talk to women, we usually ask them to lose weight, especially if they have polycystic ovarian syndrome, because in and of itself, PCOS causes you to not ovulate. Having extra weight on top of it can actually be worse. I, fortunately or unfortunately, have PCOS, but I have a low body weight. 20% of women that have PCOS have low body weight. And so when you're looking at me, you won't know that I have PCOS, right? But that also means that I try to keep my weight down. And so everybody talks about me working out, and that is one of the reasons, because I have PCOS. And so one of the things that I would encourage anyone to do is, if you have a high body weight, is to at least lose 10% of your body weight, because 10% of your body weight allows you to ovulate again normally. That is actually the kind of the parameter that we use. Every person is different, but that's the parameter that we use. So if you're 200 pounds and you drop 20 pounds, then a lot of the times your body starts to be like, oh, she's ready to have a baby. Let's do this. And so that's what happens with that. When you have low body weight, what's happening is that your body is like, yeah, she's not ready to have a baby. She doesn't have enough fats. So why would we ovulate right now? She's working out too much. She's running marathons. Why should a baby's not going to survive in a woman that's running marathons all day. Like, so that's where the low body weight comes in. And so there's athlete syndrome. There's also hypothalamic amenorrhea, like we discussed earlier. So that's kind of the answer to that question. I hope that kind of explains it well.
Awesome. While we're on this conversation of weight, one of the questions was, are there any foods that inhibit fertility, that anything that, you know, will stop them from ovulating or things like that?
So I have to always preface when I start to talk about lifestyle that I am a evidence-based physician. So I talk about things from that standpoint. That does not mean that anecdotal things don't work, but it is where the field from which I am trained. So I'm actually going to answer this question backwards, but I will get to the question. The first thing is there a fertility diet? That's probably what I would want to know if I was trying to have a baby right now, is what should I be eating? And there's a story out there that the royal couple in the UK, William and Kate, were vegan for 2 years before they tried to conceive. And if I was the royal obstetrician, I would be sweating bullets. But they were, you know, they tried to get the best egg and the best sperm. And that's what they thought was going to help them. So the question now is, should we all be vegan, right? Should we all be eating this super clean diet? And I don't necessarily subscribe to any one elimination diet, but there is what they call a fertility diet that has kind of been studied and has had mixed results. The fertility diet includes high dairy. That's definitely not vegan. I started there for a reason. Less trans fat and more monosaturated fat. More getting your proteins from plants as opposed to getting your proteins from meats. And there's a whole host of other things that you can actually find in the fertility diet. Will the fertility diet hurt? Absolutely not. The fertility diet will actually probably help, especially overweight women. It probably will not help underweight women. So if you have a way that you want to lose weight, you can actually kill two birds with one stone. Adopting this lifestyle, because it's really not a diet, it is a lifestyle, and you will be healthier overall. And then you also probably will lose weight because you're no longer eating, and I am a pizza lover, so you're probably no longer eating pizza. You're probably no longer eating a lot of meats that may be stuffed full of hormones. So I just wanted to let people know kind of like that's a thing. And then, so what could make so now I'm answering the question. The things that have been proven for both male and female is smoking. Nobody that should be trying to conceive should be smoking. There are actually some reproductive endocrinologists who will not treat a woman or a man or a couple or any kind of combination of couples unless you have not been smoking for at least 8 weeks. So if you're trying to conceive, that would be the first thing. The second thing has not been proven in the male partner, but there have been some studies that show that when you stop alcohol, that your sperm count can be adjusted. And the sperm count will include, or the sperm analysis, semen analysis, really include the way that the sperm moves, the motility, the number of sperm in there, and the morphology, or the way the sperm looks. So, and men make sperm continuously, so it is actually a reflection of their lifestyle at any time, as opposed to us. Our destiny was predetermined before we were born. So as far as it comes to our eggs. So that's kind of like, a thing. So alcohol, the limits they say is 2 drinks a day. So if you are drinking more than 2 drinks, I would say to cut it out and cut it down. And if you want to be, purist, you can cut it out altogether. And those are the 2 things that are actually really proven. Now, I want to add one more thing, which are supplements. What are some supplements that can actually help? Some supplements that have been proven to work are CoQ10. So CoQ10 helps with the support of eggs, the egg quality, mostly in women over 30 or women that have PCOS, because women that have PCOS tend to have a lot of eggs because the problem is they're not releasing the eggs. The egg quality isn't necessarily preserved because their eggs are there, but are they good eggs? That's one thing to think about. And the other thing has been Ovasitol. Ovasitol is a supplement that can be bought over the counter. And Ovasitol also helps with the it actually helps with ovulation, really, releasing of the eggs.
Awesome. We are looking at the questions here, and I think one that was asked frequently is there an average time after stopping birth control that couples experience infertility?
Okay, so birth control is a really big topic, and I think this is a really good one to tackle early so that any questions, additional questions, we can deal with them. So what we consider birth control, I really should get into policy to try to push the name from birth control to hormonal medicines, because they're used for way more than just birth control. And many of you that are trying to get pregnant and your doctor is like, I'm gonna put you on birth control before you start your treatment, you're like, wait, what? I'm trying to get pregnant, not trying to stop pregnancy, but it's because we have to treat whatever you have with hormones. So that's kind of a misnomer in my opinion. So the birth control in general, and when we're talking about medicines, consists of either estrogen by itself or estrogen with progesterone or progesterone by itself. So estrogen is not given in a formulation by itself when we're talking about birth control. So the combined estrogen and progesterone are either pills, given out in pills, patches, or rings, and progesterone only can be pills again, injection, the Nexplanon insert, and the IUDs, okay? So each one of these act differently. So the easiest to reverse is actually the most effective. Nexplanon is the most effective. It's actually more effective than getting your tube side. And the reason why it's more effective than getting your tube side is because you can get pregnant in your tubes. So it's like 0.05% of pregnancy while you have the Nexplanon in 3 years. And so when you remove it, actually, I always tell my patients, you sure you want to get pregnant? You're walking out the door, and you're walking out the door with no contraception. I'm going to see you back. And they're like, no, that's terrible. I'm not so sure if I'm going to get, and they all come back pregnant. So Nexplanon really, once you take out the rod, you are fertile, because the half-life of eternogestrel in the IUD, in the rod is very slow half-life, very short half-life. So that is different. Second is IUDs. IUDs, same thing. You have levonorgestrel in it. Once you pull it, you also have an increase, also return to fertility is pretty fast. And there's actually the CHOICE study. It's a study that looked at all the birth controls. And one part of the study looked at the return to fertility after we removed or discontinued the birth control. And it shows that almost all levonorgestrel birth controls, which include Mirena, Kylena,
here you can watch
Skylar, all of those, they all have the same levonorgestrel in them with different doses. And once you pull that, usually return to fertility is pretty swift. Now, this is the one that I recommend no woman who wants to get pregnant in the next 3 years should ever be on. And that is Depo-Provera. Depo-Provera is a deposition of progesterone in your body through an injection. It's 150 milligrams at once. And it's supposed to disintegrate or be used over the next 3 months. The problem is the return to fertility can be really, 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 really long. So about 60% of women will get pregnant within a year after being on Depo. and return to normal ovulation. Because there is something called depot-induced amenorrhea. You're not ovulating once you have it in you. And there's actually a significant amount of women who will not have normal function for 18 months after. So that is why I actually ask my patients, do you want to get pregnant in the next 3 months? Or 3 years, sorry, because I will not give you depot, or you can ask for it and I'm not going to say no, but I'm going to give you all the risks.
Great, that's great information to have. The next question that we're looking at here is, how does sleep affect fertility? So we have some people that have, really hard time sleeping, and, they're just wondering if that kind of affects how fertile they are.
So that's a really good question, because it's one of the things that I find has a dearth of information. So there's not enough information about how sleep affects us in general and how sleep affects fertility. We know that stress affects fertility. We know that fertility, I always explain the way that the body ovulates like a departmental meeting. One part of the brain, Department A, talks to another part of the brain, Department B. The hypothalamus will talk to the pituitary gland, the anterior pituitary gland. And then that's going to release hormones. And those hormones actually circulate and reach the ovary, which is Department C. And once you get to the ovary is now going to start giving off hormones. It's going to make sure that, okay, the uterus is going to grow well. You're going to release that dominant follicle. So those are all different things. Well, if you are stressed out, there is a possibility that the hypothalamus never talks to the pituitary gland. And even if it does, the pituitary gland is like, yo, I'm stressed out, I ain't got time for this. So there's a lot of different layers that have to happen. And I will say this, there's actually been a couple of articles. I started to write one and I was like, I'm too busy. But there have been a couple of articles saying that even though we are locked in during a pandemic, and everyone's like, oh, in 10 months it's going to be horrible. It's not the same as a short-term issue like Sandy, the storm Sandy. During pandemics, there's actually been a steady or decline in fertility in most of the pandemics because people are so stressed out. So they're not ovulating. They're having a whole bunch of sex, but they're not ovulating. And so they're not getting pregnant. So I don't know how true that's going to be for this. Obviously, we don't know yet, but I just wanted to put that out there that, stress is so relatable, and stress may or may not affect your sleep. And the opposite, the contralateral is the same, that your sleep may affect your stress. So we don't know whether the chicken came before the egg or the egg came before the chicken.
Gotcha. One of the next questions that we have going on is, how can people improve or promote their cervical lining, and how can they improve their egg quality on their fertility journeys?
So those are two different things. So cervical lining, I think that might have been a mistype, because your cervix has very little to do with implantation of the uterus. You actually don't want it because it's called a cervical ectopic pregnancy, and those are very difficult to treat. So I think it might have been the endometrial lining or the cavity. And I actually brought this from the office. Let's see if I can get it. To kind of, it's my friend. I still have to name her. You guys need to help me. But, where the baby is in here, okay? And the cervix itself is only this short little thing. So we don't care about the lining in here. What we care about when it comes to the cervix is that it's open. It's open enough for you to have sperm, because this is the vagina, the sperm has to go in through here. So we need it to be open enough for sperm to get in, but secure enough that the baby doesn't fall out. That's called cervical incompetency. So what we're thinking about is the lining of the uterus. Well, the lining of the uterus is fluffed up by estrogen, okay? And it is thinned out by progesterone, okay? And so that's why you don't get pregnant twice. while you're already pregnant, because progesterone is dominated, it's made by a corpus luteum, which is a cyst in the ovary that sustains the pregnancy until a placenta is formed, and it gives off progesterone. And progesterone is going to thin out the lining so you don't have another implantation, if that makes sense. So, and then you'll have twins, you'll have heterotopic pregnancies, which are pregnancies one place and another place at the same time, but those all occur at the same time. You don't have a baby that's 8 months and another baby that's 6 months, or a baby that because of the lining of the uterus. So how do you promote it? That is usually done by reproductive endocrinologists who will determine if you need promotion. Because most women have normal lining of their uteruses. Most of fertility, I think we should take a step back. Most of the fertility, the way that infertility works is about 30% is male factor. Okay, I'm a gynecologist, so I don't take care of men widely. I take care of them for very small things. And I'm talking about biological men. And then about 40% is caused by women factor or female factor. And the other 30% is unexplained, or it could be more than one. So when we're talking about the 40%, we have to talk about, is that departmental meeting happening? If it's happening, that's one thing. The second is, are your tubes open? The tubes have to be open because that is where the sperm and the egg meet, unless you're getting IVF and the sperm and the egg meet outside of the body. And then the next is, do you have anything structural in here, like polyps, fibroids, that are causing you to not have space for it, or the right space for you to be implanted? And lastly, we talk about eggs. Do you have them, and are they good quality? So that's kind of the breakdown. That's Fertility 101.
Awesome. That was definitely helpful for me. So I hope it was helpful for you guys. One of the next questions that we have here is, how does age affect fertility chances?
Okay, so we'll talk about women and men separately. So I'm 34 and I don't have children. So this is the topic of conversation for your girl. So age decline fertility is so real. So as we get older, because I said our destinies are predetermined, we are born with a certain amount of eggs, and those are the only eggs we're ever going to make. And they just decline. By the time we get to menarche, which is when we start ovulating, we've lost a whole bunch of them. And every single month, we lose a whole cohort of them. We don't just lose one egg, we lose a whole cohort of them. And so as you get older, you're losing eggs. And in addition to losing eggs, as a woman, you are also losing the quality of the eggs, because the quality of the eggs decline. So the question that you should ask me is, I have seen on the news those 44-year-old women who are having twins, and why not me? Why not me? And the answer is, many of them actually had they actually were super fertile. So they're actually on their 8th pregnancy, 12th pregnancy. You don't know how many abortions people have had. You don't know how many miscarriages people have had. Unfortunately, this is a fertility discussion, but it is the reality of things. And so these people are super ovulators. They're people that are super fertile. So it still happens. It's less than 1% chance after the age of 44, but it happens. So age definitely, as you get older as a woman, your egg declines, and the medical term is age-related fertility decline. That is a thing. For men, and I should say, because of the egg quality in women, you tend to have increased risk of having chromosomal abnormalities. So things like Down syndrome, trisomy 18, trisomy 13, which is Williams syndrome, and Patel. So those are all, and then you have an increased risk of having miscarriages, because these chromosomal aberrations end up not aligning with real life. So the body, nature will eliminate them during a miscarriage. Miscarriage, or what we call in the medical term, spontaneous abortion. When it comes to men, they remake sperm. There is no age-related decline. However, there is one, at least one, there are probably more than that, that are more rare diseases that are associated with advanced paternal age, and that one is called Alport syndrome. Alport syndrome is when you have a connective tissue disorder where it affects the both hearing and the kidneys. So they tend to have kidney problems and hearing problems. This is the kids, the offspring of older males.
Awesome. One question that we have here too is when should people go see a fertility doctor to help get pregnant? Is there a certain timeline, or how should they go about this?
So I wanted to actually say that I missed a part of this. So that question actually, that's why I smiled. Mm-hmm. So when should you go see a fertility doctor? Let's back up a little bit and ask the first question is, when should you see your gynecologist? Every year, like literally. You need to see a gynecologist every year. And I want you to also, I usually tell my patients, see me on your birthday week. That way I can give you a birthday hug and I can also see you, because you'll never forget. You turn the same age, you see your gynecologist and get everything taken care of. You should also, if you have the opportunity, have a preconception workup. Unfortunately, 40 to 50% of all pregnancies are unintended, so they don't have a chance to see a physician before, because you want to work up and treat any things that can be treated before. Now, your physician should always have a conversation with you after the age of 30 as to your plans for your family. And if they don't bring it up, you do. Let them know, hey, I would like to have a baby at some point in my life. And I am in medical school, I am in law school, I am in this. I don't plan on having a kid for the next 5 years. And then they may send you to a fertility specialist to discuss freezing your eggs. Because oocyte cryopreservation, there are a bunch of studies that say between 33 and 34 is the best time, because if you don't have a partner at that time, it's the best money for you still have young eggs, but then you are probably gonna need them in the future. So I've been sharing a lot about myself. I am in the process of freezing my eggs. I'm a man, but I'm not sure when we're gonna have a baby. So that's kind of one of the reasons why you should see a fertility specialist. The second reason is, if you are seeing your physician and it doesn't seem like there's any progress in your PCOS, and you have fibroids, they're not saying anything about it, then you need to either seek an opinion from another gynecologist or see a reproductive endocrinologist. And the definition of fertility is as follows. If you are less than the age of 35 and you've been having regular intercourse with the intention of getting pregnant with no contraceptives, unprotected, and you haven't gotten pregnant in 1 year or 12 months, you need to see a reproductive endocrinologist. If you are greater than 35, you need to see an endocrinologist within 6 months of the same parameters. If you are over the age of 40, immediately. That is the parameters.
Perfect. Let's see here for the next question we have. What is your advice to women who can't afford to do treatments and seek a fertility doctor? What can they do, or what are the resources?
So I actually wrote this down because I had heard about it, but because I don't do this on a regular basis, so you'll see me rustling my papers, there are a lot of grants, actually. So I have the person that's doing the freezing my eggs. We had a lot of conversations about it. I was trying to get resources for my patients, because I see some patients who cannot afford it. And that should not preclude you from having a baby. This is not supposed to be an elitist system where we only allow women and men or couples who have the money to get babies, right? So the way to do it is, there are some grants. There is the giftofparenthood.org. There's Hope for Fertility. There's resolve.org. And then you should also talk to your actual provider. So I trained at Washington Hospital Center, Georgetown University in DC. And so Shady Grove is now all over the place, but they really were in DC. So I trained with Dr. Nair, that's who I did my rotations with. And she discussed with me that Shady Grove actually has payment plan They have charity care. So be very purposeful. Talk to them, say to them, I cannot afford this, but I really need a baby. And I really need to see if you guys have any charity care. Do you know of anyone? Do you know of any grants? I would like to apply. Apply. All they can say is no. No ain't gonna hurt you.
That's all the questions that we have. I did see that Chambery asked a question in our chat here, so I want to make sure we address that as well. So this was about the diet that you were talking about earlier, the fertility diet. She was asking if that is the anti-inflammatory diet.
I'm not very familiar with the anti-inflammatory diet, so I can't answer if it's the same thing. But I would actually encourage any woman listening to this to Google fertility diet. It gives you actually like the rules. And like I said, there are some things that are not proven by science, and there are some things that will not hurt you. So if it's not hurting you and can only help, I actually encourage women to get on those kind of things. Now, if it's going to hurt you, I'm not going to tell you to hurt yourself. But yeah.
Awesome. Like I said, one more question here. I have severe pain after HSG testing. Is that normal?
Yes, and it's really sad. There's a new test called FemView. I actually do FemView. FemView is an alternative for HSG. What we do is we do a transvaginal ultrasound, and we have a chamber that injects a little bit of water and a little bit of air. And so it comes up on the ultrasound as bubbles. So if I see the bubbles going through the cavity normally, and I see the bubbles going through into the cavity, into the fallopian tubes and spilling out into, then I know that it's normal. The things that could preclude you from doing that is, one, your physician doesn't know how to do it. It's just rare. I actually found out about it from a friend of mine who's a reproductive endocrinologist who was like, you can do that in your office. You don't have to send it for HSG, learn this. So that's how I learned it. And then the second thing is, the reason that precludes it is you can have a lot of bowel gas. And so it forms a hazy curtain and we can't see very well. Those are the two reasons why I send patients to the gated HSG. But the contrast diet itself is really little, but it's irritative for a lot of women. When I was training, they used to make us go to watch these. And I literally, like, as a small medical student, I would be like, I'll just hold your hand while you go through this. But almost every woman, because it's not a type of, there's no kind of pain that has prepared you for that.
Gotcha. She's asking as well, can HSG make endo worse?
So there have been no proven studies that show that. But what can happen is that you can feel, when you have endometriosis, you tend to have hyperexcitable nerves. And that is one of the reasons why after surgery for endometriosis, you still have pain. So, because your nerves are already hyperexcitable. So one of the things that happens is that you feel the pain more than other people because you already have nerves that if it's like this, it's like, whoa, that's what happens.
Great. Another question in here, can we improve egg quality naturally?
That was what I discussed earlier, is using the CoQ10. That's the only thing that I know has been proven to work. And that's all I can recommend because that's the only thing I have read. That there is a, I don't know enough about this to actually recommend it. And speaking of, I need to learn a little bit more, but it's DHEA has also been proven. I think it's DHEA sulfate, but I'm not sure enough to recommend it. I apologize.
Awesome. If you guys have any more questions, please use the chat function on the bottom for us so we can get you guys an answer in there. But that was very informational, very helpful. I know, especially for me, and I'm not even, trying to get pregnant, but that was super informational for me. So I hope it was helpful.
I want to say something while we're waiting. Oh, somebody said I have. Go back to work. Okay. Thank you so much. That was really nice of you. But what I want to say before everyone leaves or before we end this is there is a part of the fertility journey that people don't really emphasize, and that's the mental part. Fertility is really stressful on the couple, on the individuals, and on the marriage itself. So one of the things that I talk to my patients about when they're going through this journey is, how are you guys doing? Are you guys okay? Is your marriage solid? A lot of the times, sometimes people are so stressed out that they can't even ovulate because they're so stressed out. So one of the things that I would employ any woman who hears this webinar to do, who's trying to conceive, is really work on your mental health. Because there is no point in having a broken marriage or fractured marriage, and then you end up being successful. Okay, so what now? You don't have a marriage anymore. So I really want us to never forget that part and address your mental health while you're going through this journey.
Yes, and that's something here at Pink Stork that we are, stressing as well. So I'm very happy to hear you refer to that. Jacqueline is asking, should our husbands check their sperm to make sure that they are able to have kids?
So always when we're going, that's the first thing I do. During the initial workup, I actually do not see fertility patients alone. I always bring their husbands in because it's a couple's issue. And so I make sure I ask him stuff like, I actually try to talk to him alone because sometimes men have impregnated women and never told their spouse. So I want to know, do you have primary infertility or secondary infertility? Meaning, have you gotten someone else pregnant, gotten a whole bunch of people pregnant? I want to know, because then we know that you can get someone pregnant. And then also, we always do a semen analysis as a baseline, because I could spend my whole life trying to work up this woman's fibroids, do her surgery, and then you don't even have sperm. So.
Great. Raina is asking, how common is secondary infertility after having one successful pregnancy naturally?
So commonness doesn't really matter, because if it happens to you, you're 100%, right? So there are lots of women who have secondary infertility. And really what happens is that it most likely is a result of increasing age. So when it comes to, because you have primary fertility, like you've been fertile before, but then over time, and then the other question is, do you have a new partner? Do you have a new partner? Do you have a second husband? Do you have a third husband? Do you have a fourth husband? Like, that's always an issue. Sometimes a lot of women come in with their spouses. I can't tell you how common this is. You're probably gonna facepalm when you hear this, but they have gotten their tubes tied after their fourth kid, and they never told their partner. And so they've been having relentless intercourse with this man for 2 years, who's their new husband, and he has no clue that. And then when she finally gets to me and I talk to her separately, and I say, I saw your op report from your last C-section. It is not a repeat C-section. It is a repeat C-section with a bilateral salpingectomy. You don't have tubes, my dear. And they're like, oh. Or I've heard patients actually say to me, like, I got my tubes tied once, but I need it tied again. I'm like, now we have a problem with understanding what happened, okay? So those are things that need to be addressed. So frequent miscarriages. So we consider recurrent pregnancy loss is the medical term, when you have had 3 miscarriages or more. So anything more than 2 miscarriages, so it's 3 miscarriages or more. When you have that, you need to have a specific workup, and it is beyond a general GYN workup. So there are 2 types of people that can do this workup. It can either be a fertility specialist or a high-risk obstetrician. If you don't have a fertility specialist in your area, then a high-risk obstetrician can do that. And a lot of the times you can have something like anti-phospholipid antibody syndrome, which is when you make antibodies to the phospholipids in your body. Phospholipids are on every growing cell. So basically what's happening is those antibodies are attacking that, and you're not allowing a fetus to live. I've had patients like that. And so you need to have a full workup There are multiple other tests that you wouldn't get, and your obstetrician can order it, your gynecologist can order it, but they shouldn't be the one to interpret and manage it. That's beyond our scope of practice. How often should, oh, that's a beautiful question. Beautiful, beautiful, beautiful question, because every time you see a couple trying to conceive online, they basically are like, I'm ovulating, it's time to have sex. And that's not how it works. So during your fertility window, you should be having intercourse every other day. Just think about it. When guys ejaculate, they have sex, are they ready to go right away? You're ready to go right away. They're not. They need time, a convalescent period to that's the same way. You want the best quality sperm. So you need to give them a break for them to rejuvenate and then have intercourse. So it should be every other day within the fertility window. That's a great question.
Great. If you guys have any other questions, please type them now. But we don't have any more questions right now. So this was super helpful. We want to thank everybody for coming, everybody for showing up. I hope this was informational for you guys. I hope this helped you guys out a lot. And I just want to say a special thank you to Dr. Arumala for coming out here and helping us and answering all of the questions for you guys. It looks like we have one question rolling in here. What type of things should we take into consideration when looking for a great physician?
I love this question. I love this question because I really want to tell people what a good physician is. What you want to look for is three things. The first thing is you want to know how that person treats their staff, because you cannot fake it. So what I normally tell patients is, especially we're moving into a world of telemedicine, is call the staff, kind of initiate a little, doctor, how is this doctor? Like give them a lot of like different fillers so you can try to feel how they take care of their staff. That would give you a good, because people can't fake it. They can fake it with you for the 45 minutes, the 15 minutes you're in their office. They can't do that. The second thing is read their reviews, but be wise about it. If you have 45 good reviews and there's a one-off, that one-off person is probably pissed off they didn't give them narcotics or something. So be very mindful of that. And then the last thing is you are not married to any physician. If you see a physician and whatever they told you doesn't merge with what you know or merge with that like intangible thought, intangible spirit, you don't go on the same date with the deadbeat every single time. You go find a new boyfriend. The same thing with a physician. If you have this weird feeling about it, your spirits don't match, then march on and march off and find a second opinion, third opinion, fourth opinion, fifth opinion if you need to.
Awesome.
So it's third time the charm. Are we gonna get off this slide where we go talk forever?
I think we should be good. We appreciate all of your time.
Yes.
Oh,
For
no.
sure. I think everyone's about to catch a flight to Texas to come to your office.
Oh, you've got to come. My office is like an extension of my apartment. It's like the same type of velvet chairs, paintings on the wall. And then my staff is like, I could not have put together a better staff. So thank you to Sam and Lisa and Donna, amazing staff. It's been my pleasure, guys, and my honor. Thank you so much.
Thank you.
Absolutely. God bless everyone.
Yeah.
Have a wonderful day.
Have a great weekend.
Bye.
Thank you.